Good evening, Rohit.
Ma'am.
Try to share your screen.
Yeah, I'll just do that. Ma'am.
Try to share your screen.
Yeah, I'll just do that. I hope it's visible now.
It's visible, but try to make it full screen.
Yeah, it's full screen only, madam. I made it full screen.
इसमें नहीं आ रहा. We can. ये हमें ना स्लाइड शो मोड में नहीं दिख रहा है रोहित.
बट मेरे यहाँ आ रहा है मैम स्लाइड शो.
तुम दोबारा एक करके करो.
मैं दोबारा करता हूँ. Is it visible now?
Now it's okay. Try to move the slides. No, it's not. Is it moving on your system?
No, it's not moving.
It's not moving here also. I don't know why every week we have this issue.
ये मैम कुछ सॉफ्टवेयर का इशू है. मेरे को कई बार ये हो चुका है. I've encountered this issue many times.
ये आप अपनी मूव ही नहीं करता है. अभी मूव करो. स्लाइड मूव हो रही है. हाँ, इसमें तो मूव हो रही है. फुल स्क्रीन मोड नहीं है ये,
लेकिन नहीं हो रही.
हाँ, तो छोड़ दे. इस पे इसी पे ले ले.
इसी पे इसी पे
ले ले. So we'll start.
इसको मैं yeah. So the time is 1 hour, ना?
हाँ, 1 hour. We usually try to keep it at 50 minutes plus some discussion.
Fine. Where is
Right, I think we are ready to begin. Dr. Aarti has also joined. So, welcome you all for this IAMM PG Masterclass on a very interesting topic. And I will request our President, Dr. Aarti, to please introduce the speaker and begin the proceedings. Thank you, ma'am.
Thank you. Thank you. First of all, thank you, Dr. Sonal, for making this a successful program, a very useful program for our PGs. And I'm especially thankful to Dr. Rohit also for taking up this topic, which, it's very easy to say or read in the textbook, but actual implementation and in actual practice, it's a challenge. And I'm sure Dr. Rohit is going to do justice. We know that. Dr. Rohit is right now, you all know, professor in the Department of Microbiology at Maulana Azad Medical College. So without much delay and looking forward to the interesting academic session, I welcome you, Dr. Rohit.
Thank you, ma'am. Thank you. I hope I'm audible.
Yes, you're audible. And before we begin, the event is being live streamed on our YouTube channel also. So in case anybody finds it difficult to attend here, they can go on to the YouTube channel and see it. So over to you, Rohit, now.
Thank you, ma'am. Thank you. At the outset, I'd like to thank Indian Association of Medical Microbiologists for having me over here. In particular, I'd like to thank the President, Dr. Aarti Kapil, and the Secretary, Dr. Sunil Saxena, for this opportunity. So let's get going. This is a topic which is both interesting and difficult. So I'll try to make it as easy as possible for us to understand. There's a lot of statistics involved, but we'll go one step at a time and try to digest what is in store for us with regard to the evaluation of diagnostic assays. Now, the first question is, what is the purpose and utility of a diagnostic assay for an infectious disease? Quite simply put, we want to answer the question whether a person has a particular infection or not. And by doing an assay, we determine whether the infectious disease for which we are doing the particular test is present or not. But this is not the only aim. We can also, with the help of diagnostic assay provide an evidence of a previous infection, and that is particularly possible with serological assays, particularly the ones which detect the antibodies. Now, what is the utility of these assays? Obviously, one of them is the clinical management. Once you diagnose a particular infectious disease, you have an evidence. Now you have to manage that condition by giving an antibiotic, or you have to treat it by giving an antimicrobial. But there are other purposes also of a diagnostic test, like screening for an asymptomatic infection. Many of the infections we know are asymptomatic, particularly if you talk about sexually transmitted infections. Bulk of the infections are hidden. They are asymptomatic. There is no symptom. So only a diagnostic assay can determine whether it is there or not. Apart from this, many of the assays are now available, particularly the molecular assays, which detect the markers for drug resistance. So this is now happening in real time, particularly with molecular assays, where not only you can detect the organism, but also can detect the markers of resistance. And a classical example of that is the CBNAT assay that we have for mycobacterium tuberculosis, which not only tells us about the presence of the agent, but also preliminary information it gives, at least with regard to the resistance to rifampicin, INH, and newer versions are available where it also detects resistance to other agents. Surveillance is an important aspect for which, for infectious diseases, we use diagnostic assays. Let's take an example of HIV. We want to know the burden of HIV infection in our country. So you do HIV sentinel surveillance, which is done every 2 years, and the underpinning aspect of that surveillance is an assay that you perform to get to know as a hard evidence how much HIV infection is there in the country, and where it is of high prevalence in high risk areas, so on and so forth. Epidemiological studies, especially as part of the outbreak investigation, if you're doing, again, diagnostic assays play an important role. We make use of these assays for disease control activity, and a classical example of that we all know is COVID-19, where the whole public health response in terms of the control activity was for the first time in the world driven by a laboratory assay, that is RT-PCR for SARS-CoV-2. So it was not only for the diagnosis of the patient, but also it had an implication for public health response. It is also used for evaluating the effectiveness of the intervention. So we put an intervention, again, perform the surveillance for a particular disease for which you had your intervention, and see whether the prevalence of infection is going down, going up. And that's how over longitudinal studies we have determined, if we talk about HIV, the prevalence is steadily going down of HIV. And this is because of these assays that we've been able to determine. So these are the wide array of applications of diagnostic assays, not only related to diagnosis of that particular condition, but there are various other aspects in which these tests are utilized. Broadly speaking, there are two types of assays, and this is not only restricted to microbiology, but other lab disciplines. These are qualitative assays and quantitative assays. So what is a qualitative versus a quantitative assay? The qualitative assay basically determines the characteristic of a property. So it gives a result either positive or negative or reactive, non-reactive. Whereas a quantitative assay, it determines the numerical value of a property. So wherein you get a result which is a numerical value, that becomes a quantitative assay, even though you might be reporting it qualitatively. And a classical example of that is ELISA. So you get a reading which is a quantitative reading, but you report it qualitative ELISA as a positive or a negative or a reactive or a non-reactive. But actually, it is an original reading that you get is basically a numerical reading. And many of the assays, the numerical reading is used to report a quantitative result. Like we do a quantitative RT-PCR, let's say for CMV or for hepatitis B virus or hepatitis C virus, we are reporting the quantitative values. So I've just given some examples other than what I just mentioned. Procalcitonin is a quantitative assay. CD4 count for HIV that we do is a quantitative assay. CMV RT-PCR is a quantitative assay, so on and so forth. ELISA, though it is a quantitative assay, but many of the ELISAs are reported qualitatively based on the cutoff. So I'm going to use these terms, so I'm defining them over here itself. Now, newer diagnostic assays, they keep on coming up, and this is because of the technological advancements. They are being developed. and they are being used, or we hope that we are going to use them in management and control of infectious diseases, as I discussed in the opening slides. But the biggest question that we have in front of us is, how useful is that newly developed assay, and in which setting you will be able to use that particular assay? How can we answer these two questions? How useful it is and which setting you can use it? This can only be answered through evaluations. These evaluations either you can do in the central lab, or a clinical setting, or a field setting, depending upon where you intend to use that particular assay. Now, how do we carry out these evaluations? Before we talk about the various parameters that we basically calculate and determine, we'll just touch upon what are the various variables which influence the performance of an assay. The biggest variable is the characteristics of a population where you're going to use that particular test, and the most important aspect is prevalence. Prevalence is also, we use another terminology for it, that is pre-test probability. I'm going to touch upon the concept of pre-test probability of prevalence later on in my subsequent slides, where I'm going to explain how prevalence affects the sensitivity, the specificity of positive or negative predictive values. So all these issues I'm going to discuss, but it is a very important determinant which governs which assay and how many assays you're going to use. Another aspect is the characteristic of an infectious agent. There could be genetic variation in an infectious agent, and if you're using a molecular assay for an original strain which has undergone genetic variation, that original assay may not be useful subsequently. And a classical example again is COVID-19. It is undergoing so many genetic variations. There could be a situation where mutations have happened in the area which are the areas where the primer is binding for RT-PCR, and therefore, if a mutation has happened, that particular assay may not be useful. So that again has to be assessed longitudinally. It also depends upon the characteristics of a test methodology, whether you're using a recombinant antibody or an antigen, or a native antigen or an antibody. We take example of serology for HIV. The initial serological tests that we had for HIV were using the cell lysates, and therefore a lot of false positives we used to get. Now we use recombinant antigens of HIV or synthetic antigens, where the false positives have come down because it is a purified version of the antigen that we are using. Another aspect which governs the performance is the manual or an automated method. So the chances of error are more in a manual assay than an automated assay, but not to say that automated assays are free of errors. Major errors can also happen sometimes if it is not performed properly, if the staff is not trained properly. So these are the various variables which influence the performance. And therefore, the evaluations have to be performed under a range of these conditions in which they are likely to be used. And it will be better if we have multi-center trials rather than a single center trial, so that we are able to cover these myriad conditions and generate a robust data. The underpinning aspect of any evaluation of a diagnostic assay is to maintain the quality while performing the evaluation, so that we are able to generate a useful, robust data that others can draw upon. So if I have a good data with me with regard to sensitivity and specificity of the assay, I can make reasonable assumptions about that assay and adopt it in my lab. If that data itself is flawed, obviously when I'm going to use that particular kit in my lab, I'll get flawed results. So therefore, evaluations have to be carried out in a very stringent fashion, fulfilling certain criteria. Then only we'll be able to generate meaningful data. Now, coming to what are the characteristics that are assessed while we carry out the diagnostic assay evaluation? They're divided into two categories: performance characteristics and operational characteristics. And both you'll realize are extremely important. Now, what are performance characteristics? And then we'll touch upon operational characteristics. Performance characteristics, we are very well aware because we use these terms very often while describing the performance of a particular assay. This includes sensitivity, specificity, positive predictive value, negative predictive value, precision. And all of these things you'll realize can be objectively calculated mathematically and can be quantified. Okay, and a lot of statistics we can do with it to derive a meaningful data. If you talk about quantitative essays, there are some additional performance characteristics that you can determine. And this again, I'm going to discuss in the subsequent slides. This includes your accuracy, reportable range. Precision is actually related to both qualitative and quantitative essays. Reportable range is a unique feature of a quantitative essay. Reference interval, again, is related to both qualitative and quantitative essay. Analytical sensitivity and analytical specificity. So again, all of these issues I'm going to discuss in my subsequent slides. Some of these are related only to a quantitative essay, some are related to both. Coming to operational characteristics, we often are not very fond of discussing these, but these are extremely pertinent because if a test, suppose, is extremely good in terms of its performance characteristics, but its operational characteristics are poor, then you'll not be able to use it. So therefore, both performance characteristics and operational characteristics have to go hand in hand for the test to gain wider acceptability. The operational characteristics include time taken to perform the essay. A rapid test takes roughly about 30 minutes or less to perform the test, whereas a central lab-based RT-PCR takes hours on end to perform the test. Technical simplicity. A rapid test is very simple to perform, whereas an RT-PCR open system is a highly complex test, and therefore you require a highly trained personnel to be able to perform the essay. User acceptability. A test may be good, but if a user, it is not acceptable to the user. Suppose that user is working in a field condition, and let's say one has to do a VDRL test over here, you require a microscope, so it is not easy in a field condition. RPR would be a better test for a field setup. Stability of the test under user conditions. So if it is a tropical area and the kit itself is sensitive to temperatures, and obviously the test may be good, but then by the time it is transported to the far-flung areas, it will not be able to maintain its performance characteristics. So therefore, stability and robustness of the test again becomes very important, specifically if you're going to use an assay in a field setting for public health purpose. And this again has got a direct bearing on the procurement decisions. That is the cold chain that needs to be maintained if it is temperature sensitive. So all of these things determine the settings in which a diagnostic assay can be used. And many of these things you'll realize are subjective. Okay, there is you don't have a quantitative method of determining this. But then nonetheless, it's extremely important. And as I said, both operational characteristics and performance characteristics are complementary to each other. So let's discuss these performance characteristics, and I'm going to discuss your common performance characteristics, and then I'm going to shift my attention to the ones which are particularly associated with quantitative essays. So when you want to assess a performance of an essay, you have to compare it with a reference standard, which in old days used to be called as a gold standard. So this term no longer is used, but then you might say, you call it as a reference standard or a gold standard. They mean the same, but reference standard is a better terminology nowadays. Now, choice of your reference standard is extremely crucial. If your choice is not good, you will get erroneous conclusions. And I'm going to come to that in a subsequent slide. But having said that, your reference standard has limitations. Most often, your reference standard that you compare with is a risky procedure, or is technically very difficult, or is a very expensive test that you do, or is impractical. And in some situations, we know that we just don't have a gold standard. Okay, so what to compare with? We just don't have a gold standard. So then it becomes pretty tricky as a situation, how to compare. Coming to a point where you choose a gold standard which is imperfect. This would lead to erroneous conclusions. So let's see how. If the new test that you've chosen with a gold standard detects diseased individuals more accurately, your actually test under evaluation is much better than the gold standard and is able to detect diseased individuals more accurately, then many of these would be labeled then as false positives because your gold standard is compromised. Conversely, if your new test that you're evaluating detects disease-free individuals more accurately, then many of these will be labeled as false negatives, but actually they were true negatives. So therefore, choosing an ideal gold standard is a very important step. If your gold standard is not chosen properly, then the conclusions that you are going to draw would be erroneous. Many times a single essay cannot be used as a gold standard, and this is particularly important in a situation where the test that you are evaluating is a highly sensitive test, let's say a PCR. In such a situation, we tend to use composite reference standard, where results of more than or equal to 2 essays are combined, and then this is taken as a gold standard, and then your new essays compared to it. So composite gold standards particularly are important in situations where you want to compare a new essay which is more sensitive, and then rather than taking one essay, you take a composite gold standard. Now coming to performance characteristics, and this 2x2 table I'm going to show you pretty often, and I really want you to understand, and given some practical examples over here, so I'm sure this will be useful for all of us. Now, when you compare your test under evaluation, you compare with the results that you get with a reference essay, that is a gold standard. And then you create what we refer to as a 2x2 table. The first cell is when your reference essay is positive and the test essay is positive. This basically means true positive. The second cell, that is B, where test under evaluation is positive, but your reference test is negative. We put it arbitrarily as B, and this is nothing but your false positive result of your test. The third cell is your test under evaluation is negative, but the reference essay is positive. So you take it arbitrarily as C, and this indicates false negative result. That is, your disease condition is present, but your test under evaluation is not able to detect it. So it is false negative compared to the reference. The fourth cell is a situation where both are negative. Your reference essay result is negative as well as your test under evaluation is negative. We conventionally take it as D, and this means it is a true negative status. So if you remember this, we'll then use this as a important 2x2 table to calculate the various performance characteristics. So first is the pre-test probability, which is nothing but prevalence, and this I mentioned earlier also. You take the sample of population in which you want to diagnose a disease, and you apply that particular test. Let's say a reference test. This reference test will detect the disease condition. So the numerator will be total number of individuals out of that sample where the disease condition was detected by the reference essay, and therefore it will be designated as diseased. Whereas the rest of the population will be not diseased. So if you calculate the diseased population and divide it by the total population, that gives you the prevalence of that particular infection as determined by the reference essay. So therefore, if you see this 2x2 table, the prevalence would be A plus T. A plus C, that is the positive as determined by the reference essay. It is your gold standard. So you take it as a reference. If it is positive, the disease condition is there. While the rest, that is A plus B plus C plus D, is the total population on from which was subjected to that particular reference essay. So that will become your denominator, and this will give you the prevalence. And this prevalence, as I said, is also referred to as pre-test probability. And I'm going to touch upon this again in just a few moments from now. So what is sensitivity? Sensitivity is also referred to as a true positive rate. So let's put it in a probabilistic function. It is defined as a probability in which we see all those individuals which are diseased. What is the probability that the test is positive? So your denominator is all those individuals which are diseased, and the numerator is out of those people, which ones are positive by your test under evaluation. So it becomes A divided by A plus C. So A divided by A plus C. False negative rate is the probabilistic function wherein all those individuals where the disease is present, what is the probability that the test under evaluation gives you a negative result? That is a false negative result. So this is also referred to as FNR. Okay. So this is C divided by A plus C. Specificity, on the other hand, is what is the probability wherein your reference result is negative, out of which what is the probability that the test under evaluation is negative. So it is D divided by B plus D. False positive rate is what is the probability that amongst those individuals where the disease is absent, that is B plus D, the test is negative, that is B divided by B plus D. So these are very simple statistics that we use to determine the performance characteristic of an essay. Now let's see what is the relationship between false negative rate and sensitivity. So false negative rate is nothing but 1 minus sensitivity. So see over here in the last slide, false negative rate is 1 minus sensitivity, whereas false positive rate is 1 minus specificity. Okay. Now coming to a very, very important aspect, which is a practical utility that we need to know, positive predictive value. Positive predictive value is what is the probability where the test under evaluation is positive and the disease is present. So what is the probability in those individuals where the test is positive and the disease is present? So the probability of disease being present in people whom the test is positive. So this is called as a post-test probability. And this is how you practically use an assay. You do a test, and if it comes out to be positive, you want to know what is the probability if the test is positive, the disease is present. Conversely, what is a negative predictive value? Negative predictive value is if the test is negative, what is the probability that the disease is absent? Okay, so if the test is negative, what is the probability if the disease is negative? So let's see, positive predictive value is nothing but A divided by A plus B, whereas negative predictive value is B divided by C plus B. Please remember, sensitivities and specificities are not related to the prevalence of infection. They are independent of the prevalence of infection, whereas PPV and NPV are related to the prevalence of infection. And I'm going to explain that in my subsequent slides. And this is an important concept that we need to understand, especially the PGs who want to understand the test performance characteristics. If it is given in published literature, what does it mean? So let's see. I'll give an example over here. You do a reference test in 16,000 people, out of which 600 are positive. And then these people, a test under evaluation is performed, and you make this 2 by 2 table. So this, all the details are given over here. So what would be the prevalence, the pre-test probability? It will be total number of people which are there as part of the study population divided by, total number of people, this will be the denominator, and numerator would be the total number of people who are diagnosed as having a disease based on the reference assay. So 600 divided by 1600, 0.37. On the other hand, let's see the sensitivity. That is a true positive rate. Sensitivity would be 570 divided by 600. 570A divided by 600 is A plus T, 0.95. So I'm putting this as decimal 0.95. Some people multiply it by 100 and then mention it as a percentage. So 0.95 is nothing but 95%. Okay, but I'm mentioning it as a proportion only. False negative rate is C divided by A plus C, that is 30 divided by 600, that is 0.05. So as you see, sensitivity plus false negative rate, if you add the two, it becomes 1. So therefore, false negative rate is 1 minus sensitivity, as we just discussed earlier. Specificity is D divided by B plus D. This is D divided by B plus D. So it is 850 divided by 1000, that is 0.85. False positive rate is nothing but 1 minus 0.85, that is 0.15. This I've already discussed how you calculate the false negative rate and false positivity rate. False negative rate is 1 minus sensitivity. False positive rate is 1 minus specificity. PPV, what is PPV? It is the probability function wherein if the test is positive, what is the chance that the person is suffering from disease? So it is 570 divided by 720, that is 0.79. Negative predictive value is what is the probability if the test is negative, the person is not suffering from disease, that is 850 divided by 880, that is 0.97. So these are the determinations that we've done based on the data, the study that we performed, wherein we compared your test under evaluation with the references. Now let's see a very important aspect. What happens to the PPV and NPV if you change the prevalence of a particular disease in a population? So this is the original example that I've given. Now I'm giving the next example where the sensitivity of the specificity of the assay remain the same, but the prevalence increases. Then the prevalence increases, you again calculate the whole thing. The positive predictive value comes out to be 0.86, whereas the negative predictive value comes out to be 0.94. So 0.86 and 0.94. Okay. If you decrease the prevalence of infection and calculate the whole thing, keeping the sensitivity and specificity as same, 0.95 as sensitivity, 0.85 as specificity, this is the positive predictive value that you get, 0.475, and negative predictive value of 0.991. So I've put it in a tabular form. This is the low prevalence. Please remember here the sensitivity and specificity remain the same, but the prevalence is changing. That's the only thing which is changing. The sensitivity and specificity remain the same. The prevalence over here is 0.125, over here is 0.375, over here it is 0.5. Okay, so PPV increases as the prevalence increases, NPV decreases as the prevalence decreases. Okay, so please remember this important set of rules now. It will make your life a bit easier. Please remember, sensitivity and specificity is independent of prevalence. It has got nothing to do with prevalence. Whatever may be the prevalence, the sensitivity and specificity of SC will remain the same. However, if prevalence of the infection increases, the positive predictive value increases and NPV decreases. If prevalence decreases, the positive predictive value decreases and the NPV increases. Now, what is the utility of this? We take a classic example of HIV. When we do an HIV testing in an asymptomatic people, we do 3 serial tests. In an asymptomatic person, the prevalence of infection in our country is 0.25%, so prevalence is low. So therefore, larger number of tests we have to do to arrive at a conclusion whether the person is diseased or not. Conversely, if you take the sample from a person who's of high risk group or has got symptoms of HIV, your pretest probability increases because your clinical symptoms indicate that the person might be suffering from HIV. In such a scenario, the number of tests that you require to diagnose the infection, in this case the HIV, decreases. So in your strategy 2B, you just have to do 2 tests. If both of them are positive, you label the person as HIV infected. Whereas in asymptomatic, that is strategy 3, you have to do as many as 3 different tests. So therefore, it is all governed by the prevalence of HIV infection, which is determined either by your clinical features or based upon the risk factor history. Now, coming to the relationship in a graphical form between PPV and prevalence, as I said, as the percentage of disease increases in the population, PPV increases. This is a graphical representation in front of you. Now, how do you, if you want to perform a study of diagnostic evaluation wherein you want to calculate the sensitivity and specificity of your new test vis-a-vis a reference test, how would you calculate the sample size? How many cases you need to, or how many patients you need to enroll? Let's do a bit of math over here. We all know increasing the sample size reduces the uncertainty regarding the estimate. In this case, the estimate, let's say, is sensitivity or specificity. And this uncertainty is determined by confidence intervals. So very simply put, narrower the confidence interval, greater is the precision of the estimate. And we normally calculate confidence intervals at 95% CI. And what does it mean? 95% CI means that you are 95% certain that the interval contains the true value of sensitivity and specificity. So narrower it is, better is the precision and more confidence you have with regard to the sensitivity and specificity data that you've generated. And this is given by a formula where P is plus minus 1.96, which is a coverage factor, that is plus minus 2 SD, into under root of P into 1 minus P divided by N, where P is the statistic, let's say sensitivity, 1 minus sensitivity divided by the sample size. Now, let's take an example over here. This is my test under evaluation, and this is the reference essay. Based on the reference essay, 97 subjects are positive, whereas my test under evaluation detects only 90 out of those 97. So my sensitivity becomes 90 divided by 97, that is 0.928. If you want to mention it percentage, we mention it as 92.8%. So if I want to calculate the 95% CI, it is very easy to calculate. 0.928 plus minus 1.96 into under root of 0.928 into 1 minus 0.128 divided by total number of sample size, that is 97. So this is the value that you get, 0.051. You add to the metric, that is the sensitivity, and subtract it, so you get a range, 0.877 to 0.979. So your sensitivity of 0.928, you are 95% sure that it lies within this range. Okay, and you can use the same formula to back calculate in order to determine sample size. So suppose you want to know how many patients I need to enroll to carry out the sensitivity and specificity study for a particular new assay. You need to know first what should be the desired sensitivity of that assay and what should be the desired precision. And you just plug into the same formula and calculate the sample size, and you can use the same formula. And suppose you want a sensitivity of 0.8% and a precision of 0.1. 0.1 precision means 10%. Sensitivity 0.8 means 80%. You plug it in, the sample size comes out to be 61.5. So you can do it yourself also later on using the same form. Now coming to the performance characteristics of a quantitative assay. Quantitative assay, as I said, generate a numerical reading. Now one of them, or the first performance characteristic that I'm going to discuss, is the reportable range. Reportable range is the span of test result values that you've established, and this range gives you accurate results within that particular span. And for a quantitative reporting of results, only those results within that particular reportable range, if they are there, they are going to be reported. That's why it is called as reportable range. Suppose, let's say I'm doing a CD4 count and my reportable range, let's say, is 50 cells per microliter to, let's say, 2000 cells per microliter. If my result falls within it, let's say 1000 cells per microliter, I'll report it as 1000 cells per microliter. If it is less than 50 cells per microliter, that is, let's say 25 cells per microliter, even if the machine is giving that, I'll report it as less than 50. If my upper limit is 2000 and my machine says it is 2500 cells per microliter, you will not report it as 2500, you'll report it as more than 2000, because after 2000 cells per microliter, you're not sure about the accuracy of the quantitative data that the machine might be generating. This reportable range, for obvious reasons, does not apply to qualitative tests, because here we have just reactive, non-reactive, positive, negative. A lot of synonyms are used, and that's why there's a lot of confusion with regard to the reportable results: measuring interval, analytical measurement range, linear range, dynamic range, so on and so forth. So these are the terminologies which are used. For every reportable range, there is a lower limit of quantification, which is also called as LLOQ, and an upper limit of quantification, which is known as ULOQ. Okay, so this is defined. So if I say for CD4 count, 50 cells per microliter, CD4 cells to 2000 cells per microliter, my LLOQ is 50 cells per microliter. My upper limit of quantitation is 2000 cells per microliter. And this has to be defined by various mathematical statistical models. So you have to design a study for that, and this has to be done by the manufacturer. And this data has to be submitted to the regulator. And based on this, you write in the performance characteristics for a quantitative result, this is the reportable range. Okay. Now, how do you do that? You test a series of samples with known concentrations or dilutions, and the measured values by the test system are compared with the assigned values. So each concentration will have a defined value. You subject it to testing. The test will generate the data. How closely they are associated will tell you whether your reportable range that you've defined is right or wrong. Okay. Now, how do you do this? You prepare what we refer to as a XY scatter plot, where X-axis gives you the assigned values. Assigned values are your concentration that is labeled on the standard that you're using. Measured value is on the Y-axis, which is what you've calculated. Okay, and you see whether there is a linear relationship between the two or not. We'll do a bit of mathematics over here. There are two statistics that you need to know, and many times you read it and sometimes you don't realize what it means. One of them is correlation coefficient, that is small r. The other one is correlation of determination, that is r square. Now, correlation coefficient, that is small r, defines the magnitude and the direction of the linear relationship. And this is calculated statistically. On the y-axis is the value that you generated by your system, and the x-axis is the nominal value or the assigned value, and you plot it based on the multiple readings on different concentrations. And you calculate an R statistically. I'm not going to go into the details how it is calculated. That's again a topic for later discussion. Just remember, small r is always between -1 and +1. +1 indicates a positive linear relationship. -1 indicates a negative linear. So this is a positive linear. This is a negative linear. 0, no linear relationship. Same r value, you can square it. And this r square value is now known as correlation of determination, which it actually indicates the proportion of variation of one variable that can be attributed to the second variable. So this variable is the assigned value. This variable is what your test has given. And by calculating the r square, you determine what is the variation of one variable which can be attributed to the other. And this is between 0 and 1, where 0 indicates that variation of y, nothing can be attributed to x. 1 indicates that there is a perfect alignment between y and x. We calculate what we refer to as a linear regression line, where y-axis is the dependent variable, that is test under evaluation, and x is your reference test. And this linear equation is given by a formula y is equal to bx plus a, where y is the predicted value that you calculate by the reading of x, where b is the slope, this is the slope, and a is the y-intercept. You move back this line, when the x is 0, whatever is y is called as the y-intercept. And by this equation, whatever value you get of x, it can be used to predict y, that is the test under evaluation. Now, if you see this regression, we want to calculate the reportable range. This is the measured value, this is the assigned value, and you calculate the linear regression and the same equation. And by this statistic, you calculate the R square. As you can see over here, R square is 0.9932. As I mentioned, once you calculate this R square 9932, if it is closer to 1, then there is a very close approximation between what you got from the test system and what is the assigned value, and therefore this reportable range is good to go. Okay, if this R square would have been poor, then there was no correlation between the two. That's how statistically you calculate. Coming to reference interval, reference intervals are the range of values which are found in individuals who do not have the disease. Okay, now it's very simple. In an infectious disease, you don't expect that the person would normally be infected. So for an infectious disease, the normal reference interval will be absence of it. So if, let's say, I'm releasing a report of HBsAg, the biological reference interval would be negative. Okay, it is as opposed to let's say in a biochemical parameter. So it's pretty easy. In case of infectious disease, normally it should not be there. Analytical sensitivity. Analytical sensitivity is the limit of detection, which is the minimum quantity of the analyte that you can detect. And we basically use again 95% CI as a model to calculate the LOD. It is a minimum quantity that you can detect. Now, this minimum quantity that you can detect, I'll graphically mention over here. This is an important diagram. Your quantitative assay, this is the lower limit of quantification. Below this, you can detect, but you cannot quantify. So this, therefore, becomes your limit of detection. Below this, you can't detect with your system. So let's say if you are CMV PCR, which is a quantitative assay, I can detect, let's say, 50 copies or 50 IU. This is my LLOQ, below which I can detect, let's say 20 IU per microliter I can detect, but I cannot quantify. So I can detect, but I can quantify. Below this, I'll not be able to detect. So please remember, for a quantitative assay, your LOD that you've calculated can be lower than LLOQ. It may be equal to LLOQ, but it cannot be higher than LLOQ. So it's not as if your LLOQ is low, but your LOD is high. So that cannot happen. LOD either would be lower than LLOQ or it would be equal to LLOQ. It can never be higher than LLOQ. Coming to precision. Precision is the closeness of agreement between the independent measurements that you obtain. And there are two words that we use for it: repeatability and reproducibility. Now, what is repeatability and reproducibility? Repeatability is within run imprecision. You do multiple replicates of testing on the same sample in the same condition, and you get percentage CV, which will be give you an idea of repeatability. If you change the operators, reagent lots, time, laboratory, all these things, you change one by one, the precision that you get is now referred to as reproducibility. So it is a larger measure of precision, whereas repeatability is the smaller measure of precision. Now, how do you do it? You keep on doing replicates of testing on the same sample. You calculate the mean and a standard deviation, and we all know percentage CV is SD divided by mean into 100. And if your percentage CV is less than 15%, it is considered to be an acceptable imprecision. Okay, and this is done as part of the study. to determine the performance characteristics. Specificity analytical, I'm not going to discuss right now. This also I'm not going to discuss. Now, this is an extremely important concept, receiver operating characteristics, or ROC curve. Now, this is a graphical representation for a test under evaluation, which is a quantitative essay. And I really want you to concentrate, because visually seeing an ROC curve will give you an idea how the test is performing in terms of its sensitivity and specificity. So it is a graphical representation of a relationship between sensitivity and specificity. There are three outcomes of ROC curve. If you make an ROC curve, you can select an optimal cutoff. You can determine an optimal cutoff, which will give you a good balance between sensitivity and specificity. And this is, as I said, to do with quantitative essays. We can also determine the accuracy of the test by just seeing the graph. And we can also compare multiple essays, and by just seeing the graph can tell which one is better in terms of its performance. So this is the ROC curve. On y-axis, we've got a true positive rate, which is the sensitivity. And on the x-axis, we've got a false positive rate. And we all have learned now, false positive rate is nothing but 1 minus specificity. And you plot these values and you get a graph. And this is called as receiver operating characteristic curve, or ROC curve. Now, if your sensitivity and specificity are 100 and 100%, you'll get a line like this. And this is a perfect test. And then we all know nothing is perfect in life. This is ideal situation where sensitivity and specificity is 100%. This is never going to be achievable. On the other hand, if the test is having poor sensitivity and specificity, you'll get a diagonal line. 50% of the chance it will be false positive, 50% of the chance it will be false negative. So therefore, it is not of good value, this test. Now, having a look at this graph over here, this is the perfect scenario. This is the imperfect scenario. If you calculate the ROC curve or make the ROC curve, it will fall somewhere in between the two. And if your curve is more towards the top left side, better is your essay in terms of sensitivity and specificity. And visually, you can actually see. Another thing that you can see with the ROC is basically the area under the curve. So this is the receiver operating characteristic curve that you made, and area under it is called as the area under the curve. And this is the measure of accuracy. Higher is the area under the curve, more accurate is the test. And if you go back and see this particular slide, just a minute. Over here, the area under the curve is 1. So it means accuracy is perfect. Here, if you see over here, area under the curve, it is less than 1. This box is taken as 1. This again, obviously, would be less than 1. Anything which is more than 0.8 is considered to be a good accuracy. Okay. Whereas 0.5 is considered to be a very poor accuracy. Okay. So 0.5 is considered to be poor accuracy. This is poor accuracy. Over here, this diagonal line, the area under the curve is 0.5. 0.5 is over here, 0.5 is over here. So this is a very bad test in terms of accuracy. Anything which is above this is a good test essay in terms of its accuracy. Third aspect is, how do you compare the essays? And here it plays a very important role. For 3 essays for a particular disease entity, I do and calculate and make an ROC curve. Out of the 3, the one which is more closer to the top left point is a better essay as compared to the other. So just by visually seeing it, you can say which test out of the 3 would have a better performance characteristic. So this is the beauty of an ROC curve. So with this, I'm through with the major aspects of the performance evaluation. I'm just going to share some questions, and you can in fact attempt them in the chat box if you like, or you can attempt them as per your own convenience. So this is a 2x2 table wherein this has been done, a study in children, where you are seeing what is the performance characteristic of signs and symptoms of pharyngitis in diagnosing group A streptococcal pharyngitis. So your reference test is group A streptococcal pharyngitis, and you've taken, let's say, 150 children as part of your study population, and then you compare how does your signs and symptoms perform as compared to isolation of group A streptococcus in cases of pharyngitis. So my first question over here is that what is the prevalence of gas pharyngitis? Unfortunately, I cannot put it in the presentation mode. So what is the prevalence of gas pharyngitis? This is nothing but gas pharyngitis is nothing but the prevalence of infection. So prevalence of infection, 150 is the number of people who were taken in the study. Out of this, 40 were positive by culture. So therefore it becomes 40 divided by 150, and therefore you will get this answer. Similar study, what is the sensitivity of signs and symptoms for diagnosis of gas pharyngitis, group A streptococcal pharyngitis? So what is sensitivity? Sensitivity is the true positive rate. So this is A, 28 divided by the total number of people who were diagnosed as having gas pharyngitis, 28 divided by 40, you will get it as 0.7. Okay. Next question, what is the positive predictive value of signs and symptoms for diagnosis of gas pharyngitis? So here, positive predictive value is what? What is the probability if the test, that is in this case, signs and symptoms are positive, that the person is suffering from disease that is having gas pharyngitis? So your denominator would be 58 and the numerator will be 28. So 28 divided by 58, it will be 0.48. Now, these are some interesting set of questions, and I want you to think about them. And this is based on the ROC curve. If a consequence of a false positive result is that the patient is subjected to a risky surgical procedure, while that of a false negative result is additional testing, which of the following positivity criteria you should select? So this is a receiver operator characteristic. Here is the sensitivity, that is 2 positive rate. Here is the false positive rate, that is 1 minus specificity, and you get these points. And the question says, if the consequence of false positive is a risky surgical procedure, whereas the consequence of false negative is additional testing. So therefore, what can you compromise on and what you cannot compromise on while deciding the cutoff? I cannot, in this question, if you see, cannot compromise on false positivity, because if the result is false positive, that individual will be subjected to a risky surgical procedure. However, I can compromise on false negativity because the consequence of false negativity is just additional testing. So therefore, I'll choose a test at a cutoff which has got a higher specificity or higher sensitivity. So I'll compromise on sensitivity, but will never compromise on specificity. So I would want a test which is more specific. More specific means less false positive rate. So this is the false positive rate, it will go close to 0. So I'll choose out of this ABC a cutoff which is C. So that's how you can have a trade-off between sensitivity and specificity depending upon how would be the outcome of a false positive or a not false negative result in terms of the consequence. Another situation, if a missed diagnosis is potentially fatal and a false positive result would only lead to additional testing. So a missed diagnosis means patient will not able to get the treatment and the patient, if it is a potentially fatal condition, might die. Whereas a false positive result would lead to an additional testing. So what can you compromise on? Can you compromise on sensitivity or specificity? So here is a situation you will never compromise on sensitivity, but you will compromise on specificity, because if the test is false negative, it could be potentially fatal, you will not diagnose it and the patient might die. So therefore, you will make or choose a cutoff in such a way that your sensitivity is highest. So your sensitivity is highest means this is a sensitivity at the top. So you see the curve, I'll choose A, where my sensitivity is highest, I can compromise on specificity. So that's how you will choose your cutoff for a quantitative parameter. Finally, again, I think you should be able to understand this. Which of the following positivity criterion should be selective if the consequences of false positive and negative result are equally harmful? So दोनों ही equally harmful है. So I'll choose a criterion which is closest to the top left corner, wherein it will have an equal trade-off between sensitivity and specificity because the consequences of both of them are equally bad. So in such a scenario, I'll choose a cutoff which is D. Okay. So I hope these discussions have been in a way fruitful for you to be able to assess a diagnostic essay. If you read a literature where sensitivity, specificity, accuracy, LQ, so on and so forth are given, you have an understanding as to what they are saying. And later on, if you want to plan a study as part of a thesis where you are comparing the two essays, one is a reference, the other one is a test under evaluation, what all statistics that you can use to come to a conclusion with regard to the performance characteristics of that particular test under evaluation. So thank you very much. Hope this session was useful to you. Now we can have questions, if any. Thank you.
Yes, any questions do we have?
Thank you, Dr. Rohit. Thank you very much. I think these are the aspects which we hardly discuss with our PGs, but they have to actually deal with in their practice. So I really enjoyed, and I'm sure all the students also took advantage of this talk. Dr. Sonal, I'll now pass it on to you for the questions.
Yes, ma'am. Actually, ma'am, there was just one question as to about some more examples. I think Rohit has elaborated everything with example. It must have been specific to a particular task. But after that, if there are any questions, you can all type. But right now, there are no questions. But I think it was so well explained that it doesn't need any queries. It's a very difficult topic to understand, which you made very easy, Rohit. So thank you so much for taking this, and I'm sure all the PGs must have benefited a lot from this.
Thank you very much. Thank you.
So if there are no questions, I think we can wind up. And
yeah.
Thank you so much, Dr. Rohit, and thank you so much, Dr. Aarti, for joining. And there are a lot of compliments for you, Rohit, in the chat box.
Yes, I think it is a difficult topic.
Yeah, I think it's a very nice idea to keep this topic because there's something which is always brushed under the carpet, and we always feel that the students would already be knowing this, and believe me, nobody knows this unless you do it and you actually practice it. We assume that they would be knowing, but that's not the case. At least my experience when I was doing my thesis was on evaluating diagnostic essays. It was really a problem for me to really understand the concepts, and it was the hard way I could. Thank you.
And a very important theory question also.
Yeah.
Many times it's a very important theory question as to how you will evaluate and what is the ROC and other things. So I think it is very useful. Thank you. And all of you stay tuned for the Antibiotic Awareness Week next month. From 18 to 21st, we are planning something good. Either we'll plan a 2-hour masterclass. We're planning 4 hours of activity on antibiotics. So if anybody wants a particular topic to be covered, please let me know either by the mail of secretary.iamm@gmail.com or sonalsaxena3@gmail.com. Right now we are at the planning stage and we can include it. But otherwise, we are going to have a session which is going to cover your antibiotic sensitivity testing, methodologies, CLSI, and molecular mechanisms as of now. So thank you so much and stay tuned for our next announcement. So with that, thank you to everybody and I'll end the meeting.
Thank you.
Thank you, Dr. Sonal. Thank you, Dr. Rohit.